Hi, thank you for joining us for using talking and translated prescription labels to improve medication adherence and outcomes. I'm Charlotte Glass. I work for Envision America. We are the makers of the Scriptability Accessible Prescription Labeling Solutions. And I am joined here today with three other wonderful women who are each going to introduce themselves and give a few of their credentials. Kristen?
Hi, I'm Kristen Byers-Jones, she, her pronouns. I am an assistant professor of clinical nursing at Oregon Health and Science University.
Leslie? Oh, you have to unmute. Oh, we still need to unmute.
Okay, there, I just got a permission.
Okay.
Good afternoon, everyone. My name is Leslie Jackson. I am an occupational therapist and an assistant professor at Indiana Wesleyan University. My clinical background largely consists of assistive technology, as well as looking at low vision and medication safety. Great to be with you all this afternoon. Thank you.
And Melania?
Can you hear me?
Yes.
Audio check. Okay, I'm Dr. Milano Lilly, and I'm a contractor for the Veterans Affairs. So I am contributing to their electronic health record modernization, and I do clinical type of assessments and data gaps for data analysis in our new EHR for end users.
Thank you all for joining me today. So I'm going to just talk a little bit about some of the common barriers to prescription labeling information. And I know all of you are in health literacy, so you're probably very familiar with all these. So I'm just going to kind of run through what my experience has been working with consumers. What we see often is that doctors do talk to their patients, obviously, about medications, but a lot happens during those appointments. And so I think providers, you really do rely upon the pharmacist to answer any questions that patients have about their medications. But we often see the pharmacy counseling is very perfunctory. Often it's declined. Those, even when they get some counseling, they have limited memory, limited ability to retain that information, especially if they're not feeling well or they're distracted, like they brought their 2-year-old with them to the pharmacy. If there's limited English, or if they don't even speak English at all, if you're hard of hearing, and you may or may not ask for sign interpretation. And then a lot of times the patient isn't even the person picking up the medications, or maybe the person picking up the medications is the patient, but they're not really the caregiver that's managing all the medications. And then a lot of times, I think a lot of us don't even think to ask the questions until we're already at home. So all of those things kind of present a barrier to really learning what we need to know about our medications while we're at the pharmacy counter. But we find that there's also barriers to the actual printed information on the medications themselves as well. So if you're visually impaired, whether it's a permanent visual impairment or something that's fluctuating, like I have a friend who, when his blood sugar is really high, his vision gets blurry. So that's just a fluctuating thing, or it's a progressive degenerative disease where the vision can alter from day to day. Then there's other print impairments that could be an issue. For example, obviously if one's illiterate, or dyslexia, traumatic brain injury, vestibular issues where you feel dizzy all the time can make it hard to read. We've also found that the label designs themselves can be difficult to navigate. Maybe it's not easy to find the information that you're looking for. And sometimes the labels don't have all the information you need. Every state mandates a different amount of information on the labels. Some states do require the indication to be put on there, but a lot of states don't at this point in time. So sometimes people have a medication and they don't really realize what they're taking it for because it doesn't say for your blood pressure or for migraines or whatever that's for. And then also sometimes the directions or the SIG is easily misunderstood. And I know like Health Literacy Wisconsin, is working hard to help doctors, change the way that we do some of those SIGs. And that's a whole conversation in itself, but that is a labeling issue as well. So when we have all these barriers to accessing that printed information on the bottle, it increases the chance for medication errors. A lot of times patients are unaware of the warnings. For example, like don't eat this with grapefruit, or you should eat it with or without food. Information about overdose, whether they're going to get drowsy or not. You might not be aware of those kinds of things. They might not be aware of what's a normal side effect. So maybe they think they're getting sicker, but really diarrhea is just a normal side effect of this drug. So sometimes those things are not known. Improper storage or disposal. I mean, most often we think of, like, should this be refrigerated or not, or exposed to sunlight or not. Being able to read the expiration date, the refill information. This is a really big one, especially for medications where you have to go back to your doctor to get the refill again. You need to know ahead of time so you can make that doctor appointment. And then overall stress and confusion can be, add a mental health, add to your mental health issues. And then eventually, sometimes people just choose not to take their medication if they can't access that information, or too afraid to take the med because they don't know enough about it. So some of the things that we've talked about can be you can be made more aware of the needs of the patient through a basic assessment, assessing the reading level, whether they can read the label or not, how proficient they are at English or the label language, assessing vision, including the intermittent vision barriers or progressive vision loss, taking into account things like diabetes, migraines, macular degeneration, glaucoma, cataracts, and then also hearing loss, because obviously, like, we don't want to suggest an audible label that doesn't have volume control, if someone has hearing loss. And then I also like to take into consideration social determinants of health. Do people have transportation to the pharmacy or to the doctor? Because that's going to make a big difference on, the availability or where they can go to get their medications. Do they need it mailed to them or delivered? That kind of thing. Limited income and insurance can come into play, like whether they can get, sometimes insurance limits what kind of medications they can get, or where they go for their prescriptions. Social isolation is a really huge one, especially during COVID. We had a lot of patients that, really rely on neighbors and friends and family to, help them manage their medications, or to read them information, read their mail, take them to doctor's appointments. And so, whenever any of those kinds of supports are taken away, it can affect the access to prescription labeling information as well. We've also come across cultural attitudes towards medications or assistance in maintaining your medications. we had, I had an advocate say, you know, like a lot of my people won't use it because they want their children to help them, because otherwise they're afraid they're going to lose that connection. And then also cultural attitudes towards caretaking and dependency, like I just mentioned. So a lot of those things come into play when we're talking about accessible labeling and managing prescriptions. And here I have a kind of an example of what accessible prescription labeling might look like. I work for Envision America. We have the Scriptability Suite. So that's on the left, the Script Talk mobile app, which reads the RFID tags out aloud. We have both translated and large print labeling. And then the RFID tags can be read on a Script Talk reader as well. And then on the right, we see Walgreens Talking Pill Reminder, CVS Spoken RX RFID tags, the TelRx digital device, Talking RX, and then an example of Braille labeling. And the last one, the blue bottle, I believe, is the Optophonic digital device.
Pardon me, Charlotte. There was a comment in the chat that someone is requesting to be able to share your screen of the slides. I don't think they're being viewed right now.
Really? Okay, well, that is not good. Can you see them now?
That's better. Thank you.
All right, well, let me, so this is the pictures of all the slides, and I'm sorry, the other ones just said exactly what I said. So we can always go back and look at those again, but I said everything that's on those out loud. So you didn't miss any information from the slide. So yeah, so I give you another second here to look at all these different options. This is not everything, but these are the ones that I know of. And these are the most commonly used solutions today. What I don't have on here is some of the other translation solutions. I know that each pharmacy, has a lot of different options because a lot of the translations come through an API and then can be printed on any kind of label. So it's really up to the pharmacies to decide what kind of label that looks like. But this translated label that you see on here is what Envision America provides through its Scriptability Suite. And then we just did our own survey during 2020. How did people, how did they feel before and after they used a Script talking label? And you can see here, a lot of people said beforehand they took the wrong medication. It was difficult to determine the right med to take. They had physical complications, emotional reactions to not being able to manage their meds on their own. They felt like they needed help or they couldn't do it by themselves. They couldn't read labels. Maybe they didn't, some said they didn't have any effect. And then some said the pharmacy, they needed help with the pharmacy. And so I was going to do just a brief demo for those who aren't familiar with Script Talk or Audible labels, so that you have a little bit better understanding of what some of the other presenters are going to talk about. So let me see here. I want to make sure that you can see this. So this is a Script Talk device. It's just a small round device. It has 3 buttons. And this one is programmed in French.
Station Scrito prête.
So then the pharmacy puts a RFID tag on the medication and programs it with all the legal prescription label information. The patient just presses the read button and then puts the label near the device.
Patient.
And it
Hugo
reads it
Blanchet.
out loud.
Médicament. Amoxicillin 500 mg tablette. Instruction. Prendre un comprimé 3 fois par jour tous les jours. Quantity 30. Date de prescription 14 octobre 2022. Expiration date 14 octobre 2023. Renouvellement restant. 3. Prescripteur. Dr. Binquet ici. Scriptability Pharmacy. Pour commander.
Right, so that's just kind of an example. This one has happened to be in French. Obviously, we have it in English. We have 24 different languages actually that we offer. And then we also have the app, and it basically functions the same way, but they can also, there's also a visual depiction of the text as well in that app. All right, we're going to move on to some examples of how this technology has been studied and utilized.
All right, that's me. So I'm just going to give you a brief overview of work that I did. This was during my doctorate program. So this was to evaluate the use of a talking prescription drug label on blood pressure and self-efficacy, and in addition to usability and usefulness. And so since you just gave a demo, I'll try to give a demo of mine, but I'm not sure. Because one of the barriers was like, for those who are hard of hearing, how loud this will be. So this is the picture of you see a blue bottle here, but this is a bottle that, like from home, of my own medication that's filled with, I don't know, candy. So I'm gonna press play here. You just press the red button.
October 25th, 2023. Dr. Jackson. CVS phone number is 555-555-1212.
Could you hear that?
At the very end, we could.
Okay. Oh, you can hear it at the end. Okay. All right. You can, next slide, please. So what I'm showing here is just kind of what I identified, from being a nurse at the bedside. I mean, we all would do, our initial, like an admission assessment, and we would inquire about patients, preferred method of learning. But I can honestly say that towards the end, when it came to discharge timeframe, that, we revisited that initial admission assessment to identify, their preferred methods, and made sure that we would incorporate those methods when they were on their way out the door. So it's kind of like my cycle, kind of a perpetuation here, where, there's not really, really standards of care that I know of, and things could have changed. I haven't been at the bedside since COVID times, actually. So maybe there's been some new standards and, within like policies and procedures at hospitals to ensure, making sure our patients understand, the healthcare information that we're providing to them. But that can lead to poor patient understanding and lack of recall. As Charlotte said earlier, people are under a lot of stress when they're admitted to the hospital. So the recall and whatnot might not register immediately. And then, you don't remember to ask any questions until you're already gone in that home. She also mentioned about, there's alternative methods that they, patients, choose to use. One, you mentioned about, choosing to have your family member provide the information to you. There's research on people using different types of rubber bands to put around the bottle, or a certain number of bands, and then that's how they would choose to identify their medications that way. And these things all result in, their dependency on other folks and other methods, rather than being, able to just take care of themselves. People want to be independent and, go through life without having to depend on others. And so that's where the self-efficacy evaluation of my research was proposed. Once you have those things, then you can consider that, adverse drug events could happen. If you're just trying to snap on a rubber band and you think, oh yeah, that might be it. If people are, visually impaired and whatnot, then that could lead to, again, adverse events. that in turn leads to exacerbations of chronic healthcare conditions, such as like a exacerbation of hypertension or a diabetic, crisis, therefore leading to, continued hospital visits and hospital care and rising in, hospital costs. Next slide. So the objectives were to evaluate the use of this label on decreasing blood pressure and also increasing a patient's self-efficacy or independence, and then evaluating the usability of the actual device itself, which is what I wanted to focus on in the beginning of my research. But I added in these other two objectives at the discretion of my professors at the time. But the focus is today is going to be on the usability. Next slide. So it was a 2-group pre-post test evaluation. So I did have a control group and I had an intervention group where one group got the device and one group didn't. This was in a free medical clinic that was in Ohio, and it was all for uninsured or underinsured folks, and all of the providers were there on a volunteer basis to provide whatever kind of services there were to provide during that clinic period. It was a randomized sampling of people who had a diagnosis of chronic hypertension. And again, they were assigned to intervention group versus a control group. Next slide. So the overall outcome was, because my study was only for a 30-day duration, most of the folks were, they were between 18 and 64 years old. The population was, my sample size was only, I think 56, 62. Hold on just a second. 52 folks. What we found between the two groups, that's the information that I did my statistics on, was between the two groups, one using the device and one not, was there wasn't a statistically significant difference in a change or a decrease in blood pressure between the groups. However, an evaluation is still open to interpretation for a within group assessment. And then there was a slight increase in self-efficacy, meaning, independence in how people felt using the device before and after. But again, it wasn't statistically significant, but there was a slight increase that could infer some clinical significance. And then again, like I said, the focus that I wanted to focus on was the usability and usefulness of the device. And so if you want to go to the next slide, I have a graph there where there were 10 questions that I asked folks who were in that intervention group after using the device for 30 days. And you can see where pretty much 3/4 of the group felt that, they rated it pretty high for, positive things, that it was easy to use and easy to turn on and off, things like that. I attribute the preference of using the label to being less than 50% because, again, this was the population was a diagnosis of chronic hypertension. And as we mentioned earlier, that folks get in their, regime of how they want to do things every day, and they get set in their ways of doing things. And, yes, they were willing to try the device, but they would probably prefer to go back to their old ways. However, they did the final question about if they would recommend it to other people to use. You could see the rating was, very high for the recommendation to use for other folks. And I have people even today saying, didn't you do, work regarding this? And, I've had family members who, friends who have had family members who've had strokes and they've mentioned like how useful, this would be in folks like them and things like that. Next slide. So this was just a brief synopsis of limitations for my study, which I mentioned already. The sample size was a little bit small. The diagnosis of chronic hypertension versus new onset, which like I said, I think attributed to the possibility of them, being stuck in their ways and the way that they identify their medication prior to using this device. The participants were limited to English speaking. I wanted to implement other languages, but that would have required hiring like an interpreter during my study to ensure that things were translated properly. This device does, you can program it in Spanish. What I have, it's only the 2 languages, but I am told that it does have more languages. I'm not sure how many, but there are other languages that are a possibility as well. And then again, that sample, the duration of the study was for 30 days. The next slide. So my recommendations were really, in doing this study was adding to the literature. When I was looking for other studies that mirrored this, there were literally only maybe 2 others. I think one was in progress at the time. So I couldn't really find anything to mirror, what I was planning on doing. So that's a positive thing. And then, as I mentioned in my cycle earlier about, considering how a label could mitigate adverse drug events, and that perpetuates the, exacerbation of healthcare conditions and rising healthcare costs. And then, why we're here today and in Charlotte's advocacy is, to try to help policymakers understand about, the adverse effects that can come out of it, the cost savings that could come out of using something like this by having things like this covered under, your existing insurance entities. And that's it for me. Thank you.
Thank you, Melania. So I'm going to take over next and talk to you a little bit about a research study that I was involved in. And of course, it started at just as the COVID pandemic had started. And I had the opportunity of working with 3 doctoral students that I taught at the time in our graduate program at Indiana Wesleyan University. Because of my interest in assistive technology and because of the interest in medication safety, as well as these types of devices to support folks with low vision, my colleagues and we undertook a study where we looked at the research behind audible prescription readers. And I saw a comment made in the chat about the references of medicines versus prescriptions. For the sake of what I'm presenting, it's going to be referred to as an audible prescription reader because, as Charlotte indicated, the Script Talk device is the information is programmed at pharmacies by the pharmacists that have access to that software technology. So I'm going to be referring to it as a prescription reader for the sake of this presentation. But in our study, what we were looking at, it was the user satisfaction or device satisfaction, as well as the accuracy among users when they were looking at using the Script Talk device to identify medication information or prescription information. The focus of our study was among community dwelling adults who we had identified in our inclusion criteria as being having at least one low vision condition. And they were also taking at least one prescription medication. So our focus were English-speaking adults who were 18 years or older. So the picture that you see there on the left-hand side just kind of reiterates the device that we were using for this particular study. Charlotte, can you advance to the next slide, please? So a little bit about our study. This mixed method study involved also a hearing screen among our participants. Because it is an audible prescription reader, we wanted to make sure that our participants had the ability to audibly have the skills to hear the device. And as Charlotte demonstrated, not only does the device read it, but there are some adjustable features, one being a volume device. So we had 4 13-dram prescription bottles that were empty, and we blinded them in such a way that the labels were covered. So we pre-identified information, that fictitious information on these 4 bottles, and we identified information from the literature of commonly used medications among adults. So for example, one of the medications was Crestor. And we blinded those bottles, so that way if anyone had residual vision, they couldn't peek at those. And we completed the hearing screen by, one, completing the training, but making sure that individuals were accurate in being able to respond back to the information. So we asked them, what was the prescription name that you just heard? What was the physician's name? And so once we confirmed what those accuracies were, we verified whether or not they met our inclusion criteria of passing our hearing screen. So our mixed method study involved a couple different assessments. First, we gathered demographic data of our participants. We had questions regarding their low vision conditions. We asked them how many medications or prescription medications they were taking at the time. We also asked questions in regards to what kinds of devices that they were, or methods they were currently using to assist them with their prescription medications. And it ranged from responses to magnification devices, some being electronic magnifiers or non-electronic magnifiers. We also had responses where individuals responded that they relied on the help of others to take their medications. So the demographic survey was one of our assessments. And then we also created a 12-item accuracy assessment. So as I mentioned, we had 4 13-dram bottles, the first bottle being the trial for the hearing screening. And we randomized the order of the last 3 bottles for our participants. But the 12 items on the accuracy assessment randomized our questions in regards to them reporting the name of the physician, the name of the prescription, as well as the dosage, as well as the instructions. And so instructions ranged from take with water to instructions of take 1 time a day, for example. And based off of their responses, we immediately recorded those after each bottle was presented, and then we indicated that on a chart and then calculated their accuracy assessment. A third device or a third assessment that we used for our study is we used the Quest 2.0, particularly the device subscale. So for those of you who may not be familiar with the Quest is a device or an assessment well documented in the literature, and it's the Quebec User Evaluation of Satisfaction for Assistive Technology. There are 2 subscales, one being the device subscale, and then another one being a service subscale. For the sake of our study, we only focused on the device subscale because we were able to get a quantitative measure or score of that. And that particular device looks at a couple key constructs when it comes to user satisfaction. And I'll show you the results on another slide, but to build off of what Melania talked about in terms of usability, the Quest looks at a couple different items when it comes to user satisfaction. So for example, it looks at dimensions, it looks at the weight of a device, it looks at adjustability, the safety or security that one would report with a device, as well as durability, ease of use, comfort, and effectiveness. So we wanted to measure those 8 constructs, and we were able to do that through the device subscale. That subscale has a Likert scale ranging from 1 to 5, 4 being satisfied or quite satisfied, and 4 being very satisfied. And so we considered satisfied if they rated a 4 or 5 on that scale. If a user on that Quest scale does not rate a 5, it does provide a qualitative section where individuals can report comments of why they didn't rate it as such. And then the last piece that we used is we had 6 qualitative interview questions where we were gathering some open-ended information regarding their likelihood to use the device in the future and gather some additional information for that. Next slide, please. Thank you. So to give you an idea of some of our demographic results in our study, unfortunately, COVID did hamper our efforts to gain additional participants. So that is one limitation of our study. But we were able to get 23 adults, and our focus for our recruitment of our study, we utilized convenience and snowball sampling, particularly with adults who participated in low vision support groups located in North Central or Central Indiana. So that's where we were able to tap into some of our participants. The average or mean age of our participants was approximately 65.4 years old. And that finding aligns with the literature in terms of the age ranges for individuals who typically have low vision conditions. But we had quite a range ranging from 44 years old up to 94 years old for our participants. They were largely female, and we had a significant range for the adults who were living with that condition, anywhere from 2 to 57 years, with the average being living with low vision for 26 years. And again, that was reflective of the literature patterns that we identified in the literature. Next slide, please. So as a result of our assessment with using the Quest 2.0, the slide that you see here, or the graph, indicates information related to the key areas in which our participants reported satisfaction with using the Script Talk device. And so as you can quickly see by the bar graph there, the adjustability was rated among 100% of our participants. They were quite satisfied with how adjustable the Script Talk device was. And we also had 100% of a percentage of our participants rating the comfort of the device. As Charlotte indicated, the device is pretty compact, very portable, very lightweight. The device has features, tactile edges, that help support the user's usability with the device to be able to distinguish the buttons. Next slide, please. And with regards to our accuracy percentages, so these were, reflects the data of our 3 bottles. And the key point to take away from this particular slide is that when it came to the actual medication names, and so for this particular slide, what you're going to see is the 3 different colors. When it came to the actual medication names, when it was information related to individuals trying to determine the actual names of the medication, this is where they were least accurate. And I think this portrays an important message, because it's a little bit easier for individuals to identify context related to take with water, because that's familiar lingo. But what it is more difficult for individuals with low vision and blindness to rely on the auditory skills is to be able to discern or distinguish information such as prescription medication or prescription names. because as we all know, those manufacturers have names that are a little bit unique and specific to those medication names. So they were least accurate when it came to the names of the actual medications. Next slide, please. Thank you. So to sum up a little bit of additional information by what I have to share with you with our qualitative results, individuals really found that when it comes to audible prescription readers, the audio quality is very important. And so we know that a lot of automated devices tend to have a little bit of a robotic tone or sound. There's not a lot of inflection of voice use or being able to enunciate certain content areas. That really impacted their satisfaction when it came to being able to distinguish and identify the prescription name. When it came to qualitative data that we analyzed, individuals were highly satisfied with the device properties of the script talked. They liked the adjustability features. They liked being able to distinguish the device features by touch and the tactile components that that the device offers. And lastly, another key theme of our qualitative data indicated that when individuals were already familiar with the prescription name, that supported their use of the audible prescription reader. So for example, one participant indicated, I recognize the name of that medication because I currently take it. And because they were familiar with the name, it was already something that they were in tune with, they were able to identify that information. So I think the message that we gained from that study and that particular item from the qualitative data is that when individuals have a new medication, it requires really more intentional efforts among the healthcare providers to spend time teaching them about how maybe that medication name, for example, may appear on the audible prescription reader or on that script talk device. So it purely identifies the importance of the information that we need to add when providing training, particularly for individuals with low vision and blindness. So I'm now going to turn it over to Kristen, and she's going to talk to you about language access in pharmacies.
Hi, everybody. I'm really glad that you're all here. It's really great to be in a conference where everyone speaks my language, and that is a pun that's intended. I want you to look at this pill bottle here and just imagine that you don't feel well. You've gone to the doctor, you really feel lousy, and maybe the doctor speaks in a language you understand by calling an interpreter, but maybe not. And they do send you to the pharmacy. You go to the pharmacy, and maybe the pharmacist gets an interpreter, maybe they don't, but they send you home with this pill bottle. You get home, you're feeling pretty lousy, and you look at this pill bottle and you know that it's important. You want to feel better, but you have no idea what to do about it. Next slide. So I teach population health nursing, and I teach in a program called ICANN. And my students provide care coordination for a set of referred clients that are mostly referred from refugee resettlement agencies, as well as some federally qualified health centers. And we certainly focus on health needs, but we also focus on social. I don't like the word social determinants. I don't like the idea that, poverty is going to impact you, determines the rest of your life. So I've been trying to switch to social influences of health or social factors of health. But anyway, we do take a very holistic approach and tackle all of it. This is a very typical photograph of this woman who has all of these medications. And some are for her, some are for her children. The students are trying to help her figure out what they are, when she's supposed to take them, how to take them. She doesn't read English, and all of these pill bottles are in English. Next slide, please. Because I think that one of the powers that nurses have is the stories that we have. And I believe that the stories can make really a big impact. I'm going to tell you a few. So I had a patient who was from Iraq. She recalls that a bomb went off in Baghdad. It released a blue powder. And since then, her whole family had asthma. Now she's landed in Portland, Oregon, and the children are in and out of the emergency room with asthma exacerbation. One of the children was hospitalized for it. So when the students and I make initial visits, we do the medication reconciliation. And we realized that she had mixed up some of the medications. She had been giving the rescue inhalers instead of the maintenance inhalers. There were several problems. Now, this woman actually had high health literacy. She spoke more languages than I speak, 4 or 5 languages. And she did not speak English. She did not read English. She was horrified to realize that the mistakes that she had made and the impact on her children. Next slide. This is a woman who delivered her baby at the hospital. And, when she left, she went to the pharmacy to pick up her medications and did not speak or read English. They sent her home with a bag of medications. She got home. She didn't know, which were for her, which were for her baby, certainly not how to take them. If the pharmacist had called an interpreter, by the time she got home, she was pretty overwhelmed. And she chose the best solution, which was not to take any of them or give any of them to her child. Next slide. So my students, besides, caring for a caseload of clients, they also have to do a population health project and really zoom out and look upstream. So, we certainly realized that we had identified a big gap in our healthcare system. So I'm not going to don't have time to go over all of it, but I'll give you a little bit of an idea of what they did. Next slide. So one of the things they did is they went to the pharmacy with their patients and just hung in the background to see what that experience was like. And they discovered that it was rare that the pharmacies called the language line, even though, the language line is not expensive, maybe $5 at the most. And some insurances do cover using interpreters. They also discovered that, and this was in their research, that a lot of the chain pharmacies in our state actually had software to translate labels into people's language. They just weren't using them. Nobody was making them. And so we quickly identified some of the problems with this. Next slide. We talked to providers, and one of the most telling story was this family nurse practitioner who said, I work with a lot of folks with non-English language preferred languages, and I spend my whole visit trying to tell them what their pill bottles say, and then we lose the time to address important health needs. Next slide. So, I'm sure you understand why this matters. I have no doubt. But there's not a lot of studies focused on the population of folks with, and I've been trying to switch from LEP, which is certainly the standard expression, limited English proficiency. I think it's a deficit-based term, so I've been trying to use non-English language preferred. But there are some studies. One of them shows that the rate of adverse events associated with medication errors is 2.5 times greater in patients with limited English proficiency compared to English-speaking patients. Another recent study showed that Hispanic parents with NELP and limited health literacy were more than twice as likely to make mistakes dosing liquid medications for their children. You can imagine the cost that are involved in adverse medication errors. There was Institute of Medicine in 2007 estimated that medication errors harm 1.5 million people every year, costing close to 3.5 billion. And the average cost of one hospitalization due to a preventable medication error is $10,000. And that was in 2001. And of course, we know that the price is much higher now. Next slide. And of course, this matters in terms of equity. You know, in 1964, the Civil Rights Act, you know, mandates that anybody who's receiving Medicaid and Medicare funds, which would include most pharmacies, need to provide meaningful language access. So this is one law. There's actually several other laws, including the Affordable Care Act. Go ahead, the next slide, please. And, you know, I've been talking about this more recently because when you provide, you go to the trouble to provide people with medication bottles that they can read, the amount of respect that you're paying that person is really not measurable, and it has huge impact. This study by Proctor in 2018 talked about the difficulty understanding written information, including prescription bottle labels, is directly related to patients with LEP being less likely to visit healthcare providers. Next slide. So my students and I were able to pass a law in 2019. This is a photo of myself and my nursing students, some of the legislators, and some members of the Board of Pharmacy celebrating our governor passing this law. Next slide. So what does the Oregon SMART law mean? So SMART stands for Safe Medications for All, requires translation. So our law is dual language. As visiting nurses, EMTs, you know, providers, we recognize that, you know, it's important for the label to include the English instructions. It also, we talked about which pharmacies this should involve. And because, you know, we were worried about some of the ma and pa independent pharmacies, but the Board of Pharmacy said, hey, look, if this is the right thing to do for any pharmacy, it needs to be the right thing for all pharmacies. So it is all outpatient pharmacies in Oregon. The provider, patient, and advocate may request a translated label. It mandates at least these 14 languages. And I can talk more about how we chose those languages. It's kind of an interesting, it was an interesting process. And it is just at least. So if there's a neighborhood that has a lot of Navajo speaking folks, they can add this. It impacts, according to the last census, you know, 220,000 Oregonians who spoke English less than very well. And this was a big deal, that we really want the directions to appear on the prescription container, not just an insert or handout. You all know that you don't look at those, and you certainly don't look at them when you're, you know, 3 times a day when you're going to go take your medication. You know, as sometime long ago, it was decided that safe practice was to put directions on the bottle for English speakers. Then it needs to be safe practice for all. Next slide. The other part of our law is that all pharmacies must post signage informing folks that that they have this right. So this is a sign that I got my university to make and translate into the 14 languages. A pharmacist can, you know, ask the patient to point to their language, but it says you have a right to free language services. Just ask your pharmacist, point to your language, and we will call an interpreter. We can also print medicine labels in your language as well as English. Next slide. The other thing that we really wanted to do is, you know, we recognize that this isn't easy for pharmacies. We are asking a lot. We're asking them to update their software, update their hardware. You know, the medical cost savings are really, who's seeing those are the hospital systems, insurance companies, not the pharmacies. So we really wanted to figure out a way to make it doable for pharmacies to do this. You know, it was hard to imagine that a pharmacist would not agree. As many of our legislators said, you know, this is a no-brainer. But, you know, how to do it is where the rubber hits the road. This is one of my team members, Dr. Park, who joined the team when he heard about the efforts of my students and I love his quote. Here he is talking at one of our Senate hearings, convincing our legislature to pass this bill. He says, we have developed a wide array of medical innovations, immune-changing drugs, electronic health records, tiny robotic surgeries, and we still have not yet figured out how to support LEP patients to simply read their prescription labels. So we do, you've already seen several demonstrations this session about creative ideas of how to fit it all on a bottle, because I did have many pharmacists say, oh, this is great, but I can't fit all this on a bottle. So there are a lot of ideas out there. There's scroll tabs, there's little tiny little booklets, there's QR codes, there's the talking pill bottles that you saw earlier, there's flags. I have a student recently whose grandmother only spoke Chinese and read Chinese, and she showed me her grandmother's pill bottle, which had this long scroll that had all the Chinese characters on it, that, you know, telling grandma how to take the medication. And again, I want to emphasize, grandma not only was taking a medication much more safely, but just felt, you know, just so respected by the healthcare system. The other thing that we're doing, you know, we're really encouraging pharmacies to, you know, have in their system the preferred language. And then recently we've had some progress with getting EPIC, which is the system most used in Oregon, to make it easier for prescribers to indicate the language that they would like on the pill bottle. Next slide. So we still have a lot of work to do. This passed in 2019 and COVID came. So we really have work to do, outreach to the public, letting them know about it. Certainly, you know, more pharmacies are adhering to this law, but we have more work to do there. And then certainly prescribers love this law, but a lot of them don't know about it. The law did not include money. So it's kind of been up to my little team and I to get this word out, and we're working hard on that. And then the other thing is just, you know, if there's anybody in the audience that would really like to bring this similar legislation in your state, I would be happy to share our materials and talk with you. We've had some success. We shared materials with Nevada, and Nevada passed a law. And right now we're working with advocates in Washington to pass a similar law. So at this point, there's very few states that have this law. We need all 50 to have this law. Next slide. I think that's it. Thank you. And there's my email address if anybody wants to get in touch. Thanks so much.
Thank you, Kristen. And that pretty much wraps it up. We were going to talk a little bit more about public policy, but I think most of our time is done, and our slides include a lot of references too. So if you want to, check out all these, HARC is going to have all the whole complete slideshow available later for download. And we'd be happy to, I know we already went over a little bit, but if anybody does have any questions, we're happy to answer those. So. And I am going to. Did I stop sharing the screen? But yeah. Okay. So just raise your hand if you do have a question and we'll call on you. Or you can put it in the chat, either way. And let's see here. Just checking the chat. There was a nice whole chat on the more accessible way of health literate way of wording medication SIGs. And yes, we are aware of that. And I know my sample did not have a very good one, but I didn't get to make my sample. Somebody else made it for me. So I was like, we need to change that, but we'll update that for the future demonstrations. Okay, well, if we don't have any questions, oh, there is a question. Magdalena, you'll have to unmute and then go ahead and ask your question.
Yes, good morning. I had a question for Kristen. I work with Washington County, and we are working with partnering with 12 community-based organizations to advance health literacy, and just wondering regarding like your pharmacy program and outreach efforts, if that, if you are partnering already with CBOs, or if how can we help? That's really my question.
Wow, music to my ears. So Washington County and Oregon.
That's great.
So,
I think
Magdalena, I put my email address in the chat. Please, please get in touch with me. I would love to partner with you.
And Fletcher had a question about, would any of the panelists be willing to help him do some research in this area? I'm a yes, I'll help you. Certainly Envision America can help you with providing some demonstration labels and samples and stuff like that if you want to utilize our solutions in your research. So that's how I can help you.
Please reach out. Be
Yeah,
happy.
I will include my contact information too in the chat. I'm at Envision America, so that is envisionamerica.com. And our 800 number is 1-800-890-1180. You can also, if it's easier, just Google scriptability or script talk, and we'll come up. But there's my email, and really, as far as demonstration units and samples and brochures and stuff like that, you can always contact us. Anyone can, you know, all advocates, we're happy to partner with you. We can help approach pharmacies to provide the service. We do work with most of the major pharmacy chains already. Or if we don't work with them, we can give you more information about, you know, where they're at in the process of getting started with. We pretty much know if they're going to do ours, or, you know, if they're, you know, what their status is, like if they're working on something else or something like that. So happy to answer any of those kinds of questions as well.
Oops.
Yeah,
There's another question, Charla.
great. Cindy, go ahead, unmute and then.
Yeah, thanks very much. I had put a question in the chat at the beginning of the session about the use of the term medications versus medicines. And so I'm always telling my colleagues, there's no reason to use the word medications, just say medicines. That's what everybody says when they're, you know, talking in real life in their living rooms and stuff. But I don't have any research that to prove to them that, you know, medicines is better understood, or, you know, in any way it's bad to say medications. Is this something that anybody left here is, you know, given some thought to, gotten any feedback on?
Cindy, I would like to maybe just kind of offer a thought to your question. I think, like so many other situations, right? It depends on the individual. It depends on the context. When some individuals, I know as a clinician, you know, refer to medicines, that sometimes is an umbrella term for a prescription versus over the counter. So in our particular study, because we were focused on an actual prescription bottle, we opted to use the term prescription for our sake of our study. I also haven't come across any necessary literature to date, you know, differentiating the two. I think sometimes it depends on your user's background and the context of what their information. Obviously, if you were working with a client who had a degree or a background in as a pharmacist, they might use, you know, terms differently. But I think it because of the script talk device that we were using, that tends to reference like a prescription bottle as compared to over the counter. So that would just be one thought that I would like to maybe offer or support in terms of your information. Thank you so much for asking.
Yeah, same thing. When we're actually talking about the prescription labeling, again, we're working with pharmacies to provide the actual prescription label in another format. So I talk about prescriptions a lot, but when we're doing customer service, you know, we can talk about medicines or medication or drugs, like whatever whatever language that the customer, the end user is using, we can mirror that. And our customer service team does a really great job with meeting customers where they're at, and we have, all over the board. For the first 20 years of our company, we primarily worked with the blind and visually impaired. And then just in the last 5 years, starting to add the translation service. So kind of branching out. But I really haven't seen any research on the language there, but yeah, we're specifically dealing with prescription labeling. So we tend to talk about prescription. Any other questions? I did want to say too, if you want to find out where scriptability is being offered, you can go to our website or you can download the Script Talk mobile app, and there's find a pharmacy features, and you can put in your location or your zip code, and it will tell you all the pharmacies in the area and what alternative formats they're offering. So. All right. Any other questions or comments? I know we wanted to make it a little more interactive and get your feedback on, your experiences, but then we all talked so much. So we're happy to get your feedback too on your experience trying to accommodate people. So.
Charlotte, I'm getting messages that they want us to wrap up so people can go to the next session.
Yeah, thank you for attending, and we appreciate you coming.
Yeah, thanks everyone.
Bye.
Thank you.